So let me just start by describing what is atrial fibrillation. Atrial fibrillation is the commonest arrhythmia that we treat. It's essentially a disorder of the electrics of the top chambers of the heart. For every normal heartbeat, we have our natural pacemaker send an electrical signal through the top chambers called the atria, and they contract synchronously. In atrial fibrillation, what happens is there's some short circuiting of the electrics. The electrical wavefront propagates abnormally through the top chambers, leading to inefficient contraction, and also often a faster heartbeat and an irregular heartbeat. This results in multiple consequences. Overall, patients with atrial fibrillation have increased heart failure, strokes, and mortality. In terms of strokes, we try and mitigate the risk of blood clots by prescribing a blood thinner or anticoagulant to reduce the risk of that. Patients with AF have increased risk of hospitalization. They have symptoms that affect quality of life, and also increased risk of overall cognitive decline over their lifetime. What I want to talk today is two aspects of our research. One on improving diagnosis of atrial fibrillation, and two in terms of improving treatments of atrial fibrillation. So I mentioned earlier that AF patients have an increased risk of stroke, and we can mitigate that somewhat by prescribing a blood thinner to thin the blood. However, many patients are sitting on AF without being aware of it. They are asymptomatic from the atrial fibrillation, and our job is to try and pick some of these people up and to institute treatments before something bad like a stroke happens. Our group has been developing different artificial intelligence models to try and address this problem. And I'll describe today some of our work using some of the newer deep learning models and applying them to ECGs to try and pick up features that suggest someone is at risk of having atrial fibrillation in the near term, so we can increase our monitoring or treat them slightly differently to our other patients. Just brief introduction on how these models work. They're sort of based on computer vision, and essentially you train a network to pick up a low versus a high risk patient from the ECG. But simplistically, just to illustrate the concept, if we have a model and we want to train it to distinguish a nought from a cross, you feed in lots of noughts and lots of crosses, and you label them so the network knows what's going on. And you'll eventually, over time, learn that a nought will comprise of vertical and horizontal lines and diagonal lines. If it sees those, it will say, I've seen a nought. But if it only sees diagonal lines and no horizontal or vertical lines, it will call it a cross. So the machine learns the features that distinguishes between the two categories. So you can apply this to ECGs, and you can feed lots and lots of ECGs into a machine and ask it to learn subtle features that distinguish high from low-risk individuals. And in this case, we fed 1.2 million different ECGs into the model with the labels of did they get AF in the follow-up period? How soon did they get AF? And what was the time from the ECG to the AF diagnosis? So the machine then learns subtle ECG features that identify patients who are about to develop AF in the next year or two. It knows what an ECG looks like for someone who will have AF in 5 or 10 years, and can distinguish that from patients who have ECGs that are low risk and those who don't develop AF over 10 or 20 years. You can then use that to risk stratify individuals as to their risk of developing AF in the next 5 or 10 years. So this is in a test set, i.e. a data set that the model has not seen in its training. So having trained the model, we then test it in an external data set. And we can see that the model is able to pick up the highest risk individuals here, shown in this maroon curve, where if you're in the top quartile of risk, over 10 years or so, you have a 40 or 50% chance of developing AF. Whereas if the model thinks you are in this low risk cohort, you really have about a 5% chance over the next 10 years. So we can then pick this group up here, identified by the machine as the highest risk, to treat differently, to perhaps monitor more closely, either with wearables or repeated hospital visits, to try and make sure we pick up the disease early so we can institute treatments. Similarly, if you look at the external validation cohort, which is to test it in another data set on the UK Biobank, which is the volunteer cohort, you can see similarly that if the model identifies someone as high risk from a single ECG, they have over the next few years a much higher risk of developing AF. So we can pick those people up for different interventions. One of the problems with machine learning is that it suffers from the explainability problem. They're often viewed as black boxes, and clinicians are somewhat skeptical of what they're doing and how they make the predictions. The predictions are very accurate, but clinicians are skeptical because they don't know why the model is making those predictions. So we've done some explainability analysis by breaking down ECG into different small bits of squiggly lines and morphologies, and try to tease out what is this that deems someone as high risk. So here we've got 3 different patterns of high risk. The red signals are the highest risk, and the blue is the lowest risk. And things that we as clinicians intuitively think of as high risk, broad QRS, left bundle branch block pattern, abnormal P waves, or these two other features, will suggest someone has had higher risk of atrial fibrillation. And it makes sense to us and perhaps gets more clinicians to buy into this new technology. You can do an average of the highest risk and the lowest risk ECGs. And again, you see there's some specific features that identify the highest risk individuals. In this case, you have sort of smaller amplitude QRS, so potentially some problem with the ventricles, heart failure that might identify these individuals as being at the highest risk of AF. And if you look at the model performance, it seems to work quite well, even if you account for all the other predictors that we know of AF. So if you adjust for age, sex, history of hypertension, diabetes, smoking history, high cholesterol, coronary disease, and heart failure, it still performs well in predicting future AF. And you can see every standardized score increase, you get an increase in the odds ratio exponentially of future atrial fibrillation. So you can use this to guide us as to identify the highest risk individuals for AF. How does this compare to existing risk scores? So at the moment, we can use age and sex, we can use the ECG parameters, we can use something called the Charge AF score, which is the gold standard in trying to predict AF risk at the moment. And you can see the AICG model appears to outperform many of these conventional risk stratification models. And if you combine them all, you get an even better performance. So it's not that we would only use this model, but we would combine them with the existing strategies. So how might this look like in clinical care? What's an example use case? You could just take every ECG that's come into your hospital and you can run them on an AI model. So here's an example of a patient, 76-year-old patient attending cardiology outpatients with coronary disease. You put it through the model and the model then predicts future disease and it gives you a score of what they're most likely to develop in the next 5 years. So in this individual, they have sort of moderate risk of mortality, low risk of heart failure. But what they found is this individual has a high risk of atrial fibrillation. And indeed, 2 years on from this ECG, this person developed atrial fibrillation. So we can use this as a model for a risk stratification, identifying high-risk individuals in the outpatient or inpatient setting to then tailor your subsequent treatments for the individual. So that's one of the pieces of work of trying to improve the diagnosis of atrial fibrillation. For the second half of the talk, I want to talk about how we've been researching improving the treatments of atrial fibrillation, specifically using something called catheter ablation, which is a procedure that we perform very commonly for patients with atrial fibrillation. Just a bit of an explanation about the biology of AF. So AF, as I said, is an electrical problem affecting the top chambers, but we know from many years of studies that the very first few beats of atrial fibrillation tend to originate in a very specific bit of the heart, which is in the pulmonary veins. These are the veins that connect into the back of the left atrium and they return blood from the lungs into the heart. And because of the way the heart develops, these sites in the veins appear to harbor about 80% of the triggers of atrial fibrillation. So the very first few beats come from the pulmonary veins. So what we do as electrophysiologists is to perform a procedure called catheter ablation, where we put tubes into the femoral vein, into the groin, all the way up to the heart, and we cross into left atrium and we perform ablation lesions, which essentially means controlled destruction of heart muscle. In this case, every single white dot here is an ablation lesion where the catheter goes to that spot, heats the tissue up for about 30 seconds, creates scar in that localized region. And the idea here is to perform 2 rings of scar that separate the pulmonary veins, which harbor the majority of the triggers of AF, from the rest of the heart. So these triggers can fire away, but they can never influence the rest of the heart, so it can never start atrial fibrillation. Now, that's been quite good for patients with paroxysmal AF. And when I talk to patients, I say there's a 70% chance that it might work with a single procedure. But in those who have persistent AF, which is a sort of more progressive form of AF, of which about 50% of patients have that form, this procedure doesn't work well at all. If you look at these Kaplan-Meier survival curves, it describes the freedom from AF following an AF ablation procedure. With a single procedure, the majority of patients after 12 months are back in AF. So it's really quite a terrible procedure. If you do more than one procedure, you can get about half of the patients free from AF for 5 years or more. So it's not bad if you do more than one procedure. But we do have a ceiling of about 50% of success, and we can't seem to break that ceiling at the moment. And part of our research is trying to identify ways to personalize treatments to improve catheter ablation for patients. One of the problems for electrophysiologists is that we still debate how atrial fibrillation is sustained electrically in the heart. So we don't really know for certain how the electrical wavefronts propagate through the atria to sustain this irregular, chaotic rhythm. There are multiple hypotheses, from a single rotational driver called a mother rotor through to multiple small wavelets that traverse the heart and sort of move around, meander, and cause the atrium to fibrillate, through to a single focus firing away. So the mechanism continues to be debated. As a result, electrophysiologists have not had a good way to ablate this kind of patients. We've tried different things, including ablating the nerves, ablating focal drivers that we find, or also compartmentalizing the atrium to different segments by drawing different lines through ablation to build out different small bits of the atrium to stop it from fibrillating. But the slightly depressing thing is the state of play is that none of these really help. So whatever we do, no matter how much ablation we do to these patients, no matter how much we add to our standard pulmonary vein isolation, patients still have a 50% success rate for persistent atrial fibrillation. So we're kind of stuck at this 50-50 toss of a coin success rate for catheter ablation. And the problem is that we continue to treat AF as a homogeneous entity. We neglect the fact that AF may be different in different individuals. There might be different electrical mechanisms at play, and we do the same ablation for every single patient. And no wonder we struggle and we fail with a 50% failure rate. Some of our other work in the lab has been to look at how fibrillation mechanism can be different in different patients under different conditions. And one of the things we looked at was how scar in the heart can affect the type of fibrillation. Now, I won't go into detail here, but you don't have to be an expert to recognize that these three signals on the top are qualitatively different. They're all fibrillation, but the one on the right certainly looks more organized, more periodic, and the one on the left looks more chaotic. And when you map the electrical pattern carefully with a high-resolution camera and look at how the wave fronts go through the heart, you can see this one on the right appears a bit more organized with a spiral wave on the right, while the other two look a bit more disorganized. So they're different types of fibrillation, and we need to be more clever about treating them differently. We looked at something else called gap junction coupling, which is how well the hearts are connected, the heart muscle cells are connected to one another. And again, without being an expert, you can see that this fibrillation on this side appears a lot more organized, very periodic signal, and this on the other side looks very disorganized and non-periodic in nature. And if you look at the high resolution maps, again, you can see some fibrillation appears very organized in the way the electrical wavefronts propagate, with a spiral wave here dominating the entire field of view, whereas you get very other messy types of propagation of electrical activity. And we've come up with this concept of the fibrillation spectrum, that there isn't one single type of AF. There are different types of AF, and we need to treat them differently. So you have very organized forms of AF that I've shown you, straight through to intermediate forms to very disorganized forms of AF. But we're now trying to map them clinically in the catheter laboratory to try and tease this out to guide our treatments for patients with AF. One of the challenges is that when you are faced with a patient, you put recording catheters into the heart, you get signals that look like this, and it's very hard to discern what's going on, and you need some clever technique to tease out the picture. And what we've done is to borrow from other fields, in this case, borrow from economics, from Sir Clive Granger, who won the Nobel Prize in 2003 for something called causality analysis. And he was keen to look at how two signals are related to one another and when one causes the other. For example, he wanted to know if inflation causes exchange rate traces. So he can then look at two signals and work out whether they're related. So we've adapted that for fibrillation. We've got the signals across different bits of the heart and tried to work out whether or not they cause one another, whether they're causally related. You can then build up a map. Although it's a chaotic rhythm, you can build up a map of how fibrillation is being propagated, how it affects different sites affect one another. And we can use this map now to personalize treatments in the catheter laboratory. So you can say this patient certainly has a certain type of atrial fibrillation based on this mapping, and we can then adapt how we ablate, where we ablate for that individual patient. So I think that's my 15 minutes. In summary, I've shown you some of our work in two aspects. One is improving the diagnosis of AF, so using AI methods to the electrocardiogram, the surface heart recording to improve the diagnosis and picking up patients at highest risk of AF. I then showed you some of the work using intracardiac recordings from inside the heart with catheters, and how we're using novel approaches to try and personalize the catheter ablation of patients with atrial fibrillation. I just want to thank the team that worked hard on this. All of this stuff is done by the PhD students and the postdocs. They deserve all the credit. Thank you very much.